Hello. Everybody hear me?
Hello.
Muted. Volume.
Hello. Evening.
Hello, Dr. Pina. How are you?
Evening, Melissa. Hi, Bijan. How are you?
Hi, Tony.
Can you hear me, Melissa?
Can I hear you? Yeah, I can hear you
I
fine.
can't hear you.
Okay.
Okay.
I can't hear anybody. I don't know why.
I'm not sure. I seem to be hearing everyone all right.
Can you hear me good, Melissa?
Yes, I can hear you just fine. Now, did you get the email from Jessica?
I'm sorry?
Did you get the email from Jessica with your slides?
Yes. Yeah, I got the slides revised. Sure.
Okay, perfect.
Okay. Am I going to project the slides or you're going to move the slides?
Yeah, so if you can go ahead and just try sharing your screen from now.
Okay, so the problem with the sharing the screen is that I'm going to miss everybody.
Oh.
Okay, all right, so let's see. Is that the way to do it?
Yeah, that would be the best option. There we go.
Do you see the screen?
Yes.
Okay, so now I'm gonna try to make a presentation. I mean the slideshow.
Yes. Yep, that works perfectly.
Now you can see, right?
Yes,
You see the single slide or you see the double slides?
the single slide.
Perfect, fantastic. Okay.
And now I'm just going to print something real fast. I'm going to mute myself and get myself off screen for just a minute, but I'll be right back.
Okay, sure.
Melissa, can you hear me?
We can.
Hi. Melissa?
Melissa is just muted. I think she moved somewhere.
Oh, okay. Okay.
And she's coming back.
Okay. Now I can hear you. That's good.
Very good.
We're right back.
Hi, Mike, how you doing?
Hey, John, is that you?
Good.
I'm doing fine. Eating my dinner, actually.
Okay. Oh. I can hear everybody in here. That's good. There we go.
How is everyone doing this evening?
Melissa, say it again.
I said, how's everyone doing this evening? Can you hear me okay, John?
Now I could hear you.
Thank goodness.
Well, I couldn't hear you on the other computer, so that's on. So
Okay,
I'm using my computer.
wonderful. I'm glad that you're able to troubleshoot it. That's why we opened this up a few minutes early so that we can, make sure the technology is working in our favor. So while we are waiting for a few more folks to arrive, here in the chat, I'm just sending some housekeeping notes. So our monthly virtual support group flyer, the next one, actually our last one for the year is going to be on Thursday, November 17th. So that is uploaded, that flyer, so you can see it.
Lactate is 100% real milk, just without lactose. Coffees too. Find it in milk the cows a little easier. Bagel says for you, 515. If you have a cold, it's not just a cold.
Oh, Brian.
Recording.
Welcome, everyone. If you can go ahead and mute yourself. And we'll be starting in just a few minutes.
Sí, ya te la mandaste para que tú la abrieras también. So she needs people.
So, hey, just want to make sure if you can hear me, go ahead and mute yourself, please. John, I also believe as host, you can also mute people.
How do I mute? I have to mute myself. I don't know how to mute.
Hello there.
Hello. Welcome, welcome. We're happy you guys are here with us.
Thank you, thank you. Thank you for the invitation.
Absolutely.
I'm not muted.
You better hit the board, okay?
I love it. What a great group. Thank you. Welcome, everybody, to FODA's quarterly Transplant Topics. We're going to be starting in just a few minutes.
I think openness is
You're muted.
Now, John, can you hear me? John?
Yep, yep.
Yeah. So since you're the host, for anyone who's not muted, we can also just either ask to mute or we can potentially mute them as well. I just want to make sure when Dr. Pina starts, we're all good to go and we're focused on him.
¿Tú estás seguro que I'm muted? It doesn't say I'm muted.
Who's that?
Sounds like Myrta. She is not muted.
I could hear you.
I'm not muted.
You're not muted.
All right, so we're going to get started in just a couple of minutes. Thank you so much for being with us.
You're hearing anybody else, but you're not muted.
She's telling me I'm not muted.
Jack.
John, since we have a couple of minutes, do you want to go ahead and just talk a little bit about FODA?
A little bit about FODA.
A little bit about FODA.
Okay, we are a nonprofit organization run by a group of recipient and donor family volunteers and family members. We support patients at all the transplant hospitals in South Florida. And what else we got, Melissa?
Well, so guys, my name is Melissa Wetzel and I am the Director of Development for FODA. We've been around for 20 years. We're celebrating our 20th anniversary this year. Super excited about that. And in addition to
Well, you know what?
our
Maybe-
emergency grant that we work with all of the social workers at all the South Florida transplant hospitals. We provide resources like these quarterly topics. We do monthly
Might fix it automatically.
virtual support groups.
No, we'll take you to 466 Lexington and we'll go to the IT department.
Yeah. So just, I want to say again, if you're not muted, if you can go ahead and mute yourself, that'll be helpful because when Dr. Pina starts talking, we're going to all want to listen in. So in the chat, I went ahead and added just a couple of flyers for reference. One is on our monthly virtual support group. This is actually our last one for the year on November 17th. And then also so excited to be able to share with you all that since COVID, this is the first time in 3 years that we are going back to Signature Grand for our annual Celebration of Life Luncheon on December 3rd. So please check it out and hopefully you're able to join us. FODA members are free, and then otherwise a paid ticket is $30 a person or $60 for a family of 4. There are details on the flyer, and then I'll go ahead and I'll send the link as well. So does anyone have any questions about FODA, or are we good to get started? Okay. I guess no questions because I asked you guys to mute yourselves. All right, so let's go ahead and get started. Very honored to be able to introduce our speaker today, Dr. Antonio Pina. He is the director of Abdominal Transplant Center and the Living Donor Liver Transplant Program at Cleveland Clinic, Florida. His medical career spans 4 decades and includes personally performing nearly 3,000 liver, kidney, and intestinal transplantation surgery. That's really incredible, Dr. Pina.
Yeah, it means that I'm old.
I'm sorry?
It means that I am old. I'm an old guy.
Seasoned?
It just means that. It just means that.
Seasoned or experienced, I think is what you mean. Yeah.
Experience is age. All right, thank you, Melissa. Good evening, everybody, and I'm very honored to be with at the Florida Organ Transplant Association tonight. And I'm also very pleased to talk to you about a very intriguing argument that has involved me seriously in the past 25, 30 years, which is the role of living donor transplantation, especially in the present era of organ and donor shortage. I don't have a conflict of interest, but as you will see in my presentation, there is probably some hidden bias, and so audience discretion is strongly advised. So what does it mean, the living donor donation in the present era of organ donor shortage? It means that we are facing a large gap between patients that are in desperate demands of organ transplants and the indication and the presence of organs available for transplantation. So let me start with the impact and the importance of living donor kidney. So this table is trying to explain to you the amount of years that you can gain with the kidney transplant instead to be on. So the red curve is the chance of dying by years if you are on dialysis and renal failure. The green is the mortality per year on the general population, and in blue is the mortality per year if you receive a kidney transplant. So as you can see, instead to be on dialysis, after a kidney transplant, you are much closer to the risk of mortality of the general population. If you stay on dialysis without a kidney transplant, your chance to die is much higher than the general population. However, the beneficial effect of kidney transplant in the patients that are on dialysis becomes smaller and smaller by time. So there is no much gain to have a kidney transplant after the age of 75, 80 years. So this means that it's very important to provide a kidney transplant as soon as a patient has been diagnosed with a kidney failure before he goes to dialysis. And then this translates in the need to have more kidney. So the kidney currently in the United States, we have 93,000 patients, 93,000 patients listed and waiting for a kidney transplant. Nationally, only one quarter, only 25% of the patients listed for a kidney transplant are able to receive a diseased donor kidney in 5 years. And despite excellent outcomes, only a small proportion of patients listed for a kidney transplant receive a living donor kidney transplantation. So kidney transplant, as I showed you before, offer improved patient survival and quality of life over dialysis. And this is universally well known. However, outcomes for kidney transplant continue to improve over time. So with kidney transplant, we can provide better and better life compared to the past. A living kidney donation has improved kidney survival in comparison to deceased kidney transplant. 1 year kidney graft survival for a deceased donor renal transplant is about 94.3% versus almost 98% if the patient receives a living donor kidney transplant. The median graft survival for deceased donor transplant is about 12 years versus almost 20 years if you receive a living donor kidney transplant. So there is definitely a much better prognosis and outcome if the patient receives a living donor kidney transplant compared to a diseased kidney transplant. Now, there is a difference if you receive a living donor kidney from one of your relatives or if you receive a living donor kidney from an unrelated donor. No, there is no difference. As you can see, only perfect sibling matching kidney donor, living donor kidney are superior in outcome compared to a living unrelated kidney transplant, which are the curves exactly in the middle. That, however, are outperforming the long-term, at 10 years, survival of the kidney compared to the deceased donor. See, the dot line is the survival curve after a deceased donor kidney transplant, which deteriorates by time. Unrelated, so a transplant performed between the spouses, so completely unrelated. A wife to husband or husband to wife, they perform much better than a deceased kidney transplant. The only superior outcome if you receive a living donor kidney transplant for your sibling. And this is translated also in another study that came from Europe, where you can see that only the perfect sibling match has a better survival than the unrelated living donor kidney transplant. But anyway, all living donor kidney transplant outperform outcome compared to deceased kidney transplantation. So increasing living donation, it's an option, especially if you can do with the kidney pair exchange that can allow for living donation in the setting of blood type incompatibility. Like for example, my brother wants to donate a kidney to me, but we are incompatible for incompatible blood type. So still, this can be achieved with the kidney pair exchange program. So my brother can donate to somebody else, and I can receive a kidney from an incompatible blood type unrelated donor they want to donate to the other patient. Voucher programs and remote donation options can allow for advanced donation and convenient donation for living donors. So you can donate in this place in Weston, and somebody else is going to receive the kidney somewhere else. there is no need for the donor to move from one place to another, just to be close to the kidney recipient. And more people are now being considered as safe candidates for living donation. In fact, nationally, United States, the number of living donors with an age higher than 55 has continued to increase. And still, there is more than 22% of living donors have been successful donating, even if they have a BMI superior of 30. So this is a good news. There is an increased number of living donors, even if they are older age than in the past, even if their BMI is higher than in the past. So the most important thing in living donor kidney transplant is how you evaluate the donor. So the most important thing is to evaluate the function of the donor kidneys in order to establish which should maintain in the donor and which kidney we are allowed safely to procure and transplant in the recipient. The potential living donor usually contacts the transplant center in order to begin the process. Our donor desk immediately starts a screening questionnaire on the phone with the potential donor. Then we move to a cross-matching the transplant recipient with the donor in order to determine if direct donation is allowed or we need to move to a kidney pair exchange, as I explained you before, in case of blood incompatibility or immunological incompatibility. Then the medical and surgical evaluation in the donor will be completed in order to be sure of the safety of the donor nephrectomy in the donor. And then we evaluate the anatomical mapping of the donor kidney before the procurement with a special three-dimensional CT scan reconstruction. At that point, we can schedule the living donor kidney transplant after the completion of the entire evaluation of the donor. What is the risk for the living donor in living donor kidney program? There is has been documented a donor perioperative mortality covering more than 10,000 operations, and the number has been between 0.03% to 0.06% of donor risk. Now, the most common causes of death in a living donor nephrectomy is pulmonary emboli, hepatitis, especially chemical hepatitis, and cardiac event, like a myocardial infarct or arrhythmia in the donor. However, this number, which may seem important, is still similar to the risk, is lower than the risk to die for a car accident in the United States. And you know how crazy it is to drive in South Florida. So still donating is less risk of dying than having a car accident, a deadly car accident in the motorway. How we are going to perform the kidney nephrectomy in the donor? Most of the time, we will perform the nephrectomy laparoscopically. So the donor, we insert these instruments inside the donor abdomen, and under optic, after we inflate the abdomen, we create a space. We are able to isolate the kidney to see the vascular supply to the kidney, and then we cut the vessel with a special stapler, with a special mechanical instrument that can seal the vessel in the kidney side and in the donor side. And then we'll do an incision in the lower part of the abdomen, which is about 6-7 centimeters long, which is similar to a C-section that can be performed in women for a childbirth. And the kidney is going to be extracted from the abdomen, from the abdominal cavity of the donor, and then be prepared on the back table, and then will be implanted into the recipient, like in a normal kidney transplant. However, sometimes the laparoscopic procedure cannot be performed for several reasons, like anatomical reasons. it's multiple vessels, or instead to use the left kidney, which is the most common size that we are using for donor nephrectomy, has to be done on the right side, because maybe the left side is the kidney that is better functioning for the donor. So in case the laparoscopic procedure cannot be done, the open procedure can be done with a small incision, which is about 10, 11 centimeters long. And through the small incision, we can isolate the kidney, the vessels, and safely remove the kidney. And still the incision remains small, about almost compatible and equivalent to the incision that we are making in the donor once we remove the kidney with the laparoscopic approach. So the living donor transplant surgery, majority of kidney donation surgery are performed laparoscopically. The donor stays in the hospital after the surgery between 1 to 2 days. Usually the surgical follow-up is in the next 2 weeks after the surgery, and then the period of recovery from the surgery. So what we recommend before the donor goes back to full work and full activity is about 3 to 4 weeks. The follow-up is at 6 months, 12 months, and 24 months following donation, especially looking at the renal function and the blood pressure of the donor. And of course, there is a lifelong commitment, must be a lifelong commitment of the donor towards a healthy lifestyle. This is the main information I was pleased to give you regarding living donor kidney transplantation. Now let me move to a more complex subject, and in some way a little bit risky, which is living donor liver transplantation. Now in living donor kidney, it may be very intuitive. We have 2 kidneys, so it's reasonable to lose 1 kidney in order to provide life to somebody else. I still keep one of the 2 kidneys. I'm a donor. But how that is going to work in living donor liver transplant when there is only a single organ? So that means that we need to divide the organ like if there are 2 organs that are connected into a midline. And why we have to do a living donor liver transplant? So first of all, this gives you the idea why we can perform a living donor liver transplant. We are used to think the liver as a single organ. Is actually there. We can make 2 organs from a single organ, dividing the liver almost in between, in two parts, perfectly functioning with a similar anatomy, specular anatomy, right and left. Vessels going to the right, vessels going to the left. Artery going to the right, artery going to the left. And the same is going to be for the outflow and the biliary duct. And we can have a different combination. From a single organ, we can divide into, we can procure a very small portion, which is the tip of the left side of the liver. We can procure from the donor a little bigger left side, okay, with a little bigger from the small tip. This is usually can be transplanted in a small adult recipient. And we can provide also from an adult donor the right side that can be transplanted safely in an adult recipient. Again, why we need to do living donor liver transplant? The same issue of the living donor kidney. The amount of patients that are waiting for a liver transplant actively in the waiting list is outnumbering the amount of liver transplant that we can do. And even if the amount of liver transplant performed from a deceased donor can increase over time, still is too low compared to the amount of patients that eventually are dying in the list waiting for a liver transplant. And in fact, if you are considering 3-year outcome of patients listed in 2012, almost 30 to 40% of patients died or were removed from the waiting list because they became too sick or because they died. And the proportion of patients still waiting in the transplant list is almost 30% since 2012. And the number of living donor liver transplant is remain plateauing, so it's still very low. To make things a little more complicated is that the way we are allocating cadaveric liver grafts in the United States is following very strictly the severity score of the patient that are waiting for a liver transplant. And this severity score, which is called MELD, is going higher and higher year by year. So in 2011, there was the mapping chart, and as you can see in Florida, the average MELD score for transplant was about 22, but now the MELD score to receive a cadaveric liver transplant in Florida, in South Florida, is almost reaching 30. So we are transplanting only very sick recipients. So what happened to the patient that have a very low MELD or a low MELD? So what happened to them is that actually, this is the low MELD score, this is the very high MELD score, and this is the medium average MELD between 15 and 24. So what happened to them is that actually they can die, because even with a low MELD, you remain listed, but almost 20% with a low MELD, they can die or they become too sick while they're waiting for a liver transplant. And the time that they are waiting before to get delisted is 243 days, which means that this patient will suffer for 243 days unnecessary waiting to be delisted because they became too sick. So being on a low MELD score, it's a double punitive, because you will be still, you will wait for a liver transplant that will never arrive, potentially. And number two, you're running a 20% of risk to be delisted because you become too sick or because you die. So there is a large gap in liver transplant between supply and demand, and it's probably even more heavy than in kidney transplantation. 20–30% of patients will never make to transplant. And the rising MELD score for transplant will means that the patient will arrive to transplant more debilitated and sicker. And there will be a longer and more complicated recovery after transplantation with the risk of dropout from the waiting list, to the point that we consider at this moment a low MELD score equivalent to high MELD score in terms of chance to die or risk to be delisted. And again, while the deceased donor remain stable, still the living donor liver transplant has a huge gap to match. And we can definitely increase the amount of patients that can receive a liver transplantation if we are increasing the living donor liver transplant, that at the present time in the United States is about 4% of all transplants. So why we are not increasing the number of living donor liver transplants? So the bad news is that with a living donor liver transplant, the donor may die and you may fall from the window. However, the good news is that you fell only once. So we need to learn from experience. And we need to learn from experience to mitigate and to decrease the chance of risk for the donor in order to increase the number of living donor liver transplantation. This procedure is underutilized in the United States because it's a complex procedure that requires a great degree of technical expertise. Unfortunately, every living donor death is well publicized. And for this reason, there are numerous regulations by UNOS and other organizations that are significant consequence for the program. So you are practically get penalized and become very difficult to start a living donor liver transplant program like we are doing now in Western. There is a risk for career for team members in case of donor death. That's made many surgeons worry about it. And people, including physicians, are not aware of the possibility to do living donor liver transplant. They are misinformed. And then around surrounding living donor liver transplant, there are a lot of myths that I like now to share with you and to clear. So most of the time, some doctors are saying that I could not have a living donor liver transplant. I will demonstrate to you that every patient can receive a living donor liver transplant. There is a myth that living donor can never be physically normal after donation. That's not true. That's not true. There is a famous soccer player, for whoever is interested in soccer, who actually, after living donor liver donation, played a final of the Champions League, and he won with the Barcelona team. Insurance will not cover living donation. That's not true, because the recipient insurance is going to cover the living donation, the living donor procedure. Living donors have to take immunosuppression after surgery. No, that's not true. The donor doesn't take immunosuppression. The recipient has to take the immunosuppression. The donor not. Outcome after living donor liver transplant is worse than the liver transplant from deceased donors. That's not true, and I will demonstrate you that actually is exactly the opposite. Patients who receive a living donor liver transplant have a better outcome than patients who receive a cadaveric liver transplant. And the MELD score has to be high in order to receive living donor liver transplant. That's not true. It's actually exactly the opposite. We like to preserve living donor liver transplant, especially for patients that have difficulty in obtaining a cadaveric liver transplant. And these are the patients, as I showed you before, with a low MELD score. The disadvantage of a living donor liver transplant is, of course, the risk for the living donor, increased risk of surgical complication in the recipient, especially technical complication, biliary, vascular, and the risk to transplant a liver that is too small for the recipient. But there are a lot of advantages. There is this decreased risk of mortality in the waiting list for the recipient. We can transplant the patient before it becomes critically ill. There is decreased waiting time for the recipient, which is important. So there is not too much time spent in the hospital waiting for a liver transplant. The transplant is elective and is not an emergency, in an emergency condition, which is better. There is a minimal cold ischemia time. We usually take the liver, we take the piece of liver from the donor and can get transplanted in a matter of 45 minutes, maximum 1 hour, since the piece of liver has been procured. And due to that, there is an immunological advantage because it's a much healthy liver, so it's less prone to rejection and less prone to damage after rejection. Of course, living donor transplant increases a lot of things like surgical stress, mental stress, emotional stress, risk of coercion, potential risk of infection, needs social support, financial burden. So, but we build up in Florida and in Cleveland main campus and in Abu Dhabi, which is the other location of the Cleveland Clinic, a very strong living donor liver transplant program that is covering all these potential aspects of living donor liver transplant. Now there is a learning curve because this is a paper that was published in 2012, was looking at all the living donor transplant done in the United States from 98 to 2009, and at that time, the publication revealed a 40% of a potential complication in the donor. After several years, this is the latest publication now from Korea, showing in 2017 that the overall complication rate is 9.3%. So now it's down from 40% to an expected 10%, which is much less. That's because there is a learning curve that we follow. And the reason for the improvement in the learning curve is because we accumulated overall experience. I did my first living donor liver transplant in Miami, when I was in Miami with Dr. Kazakis in 1998 at Jackson. And now it's 2023. So there is a long time that we spent to accumulate experience and to accumulate knowledge. There is a better patient selection with a better matching of donor recipient. There is a technical advancement, especially in the vascular reconstruction and how we modulate the portal revascularization into the small graft that we are transplanting in the recipient. There is a better understanding of the hemodynamics. So what is the relation between the amount of blood that the small piece of graft receives in the recipient and the amount of tissue that is formed by the piece of liver that we are transplanting. And there is, of course, a better management of the complication, like using ERCP, percutaneous biliary approach, and vascular intervention in case something is not doing right in the technical reconstruction of the living donor liver transplant. The most important thing is how to calculate the amount of liver that we are transplanting, but most important, how we calculate the amount of liver that needs to remain in the donor to avoid potential complication in the donor, which is our paramount important goal. Avoid any complication in the donor. And of course, if we are removing the small piece of liver that we usually transplant in the child, the remaining in the donor is 75–80%, which is perfectly safe, perfectly safe. If we are transplanting the left lobe, then we are reducing the amount of liver remaining in the donor, but it's still 60–70%. Of course, the risk is going to be more in the adult recipient that is receiving a mass of liver that is between 40–30%. If we are removing the right side of the liver from the donor, it's going to be very safe in the recipient, but a little bit risky in the donor because the amount of liver remaining is between 30–40%. So we always have to find a perfect balance in order to match the risk in the donor and the risk in the recipient. So we are using extensively in the evaluation of the donor all these new technology, which is a tridimensional reconstruction of the liver of the donor using a combination of software, computer software combination with the, uploading the imaging of MRI and CT scan. And so we can better understand the volume of the liver and the segments of the liver. And also we can map exactly which veins or which artery we have to reconstruct in the recipient. This is a right side of a liver, for example, where we knew that the amount of liver remaining in the donor was going to be more than enough to sustain her life without complication. But that was needed, the right side, transplanting the right side in the recipient needed a complex vascular reconstruction, which we planned ahead of time, and we knew exactly which vein and how to reconstruct all these veins on the back table, on the bench, before to put the liver into the recipient. And just to give you an example of the miracle of the liver as a tissue, this is a CT scan of a donor, of a real donor. She was going to donate to a friend of her, a friend, not a relative, a friend. So we calculate the volume, the entire volume of the liver before transplant. It was almost 1,400 cc, so a little less than 1.5 liters. Then we cut the liver exactly in half, okay? And the donor, we transplanted the left side of the donor liver. So we cut here, we transplanted on her friend the left side, and we kept the right side in the donor. So after 1 month, that's what we do all the time. After 1 month, we repeat a CT scan and we evaluated the volume, the new volume of the remaining right side in the donor and the volume of the left side in the recipient. And try guess what happened is that the donor, the right side of the donor, which was a little bit more than a half, regained practically the entire original volume. So after 1 month, went up to 1.2 liters, 1.2. And the left lobe, which was 300 cc, almost 300 grams, grew to almost 1 liter. So it's like we generated from 1 liver, we generated 2 livers, which is amazing. That's the capability of the liver to regenerate. And as you see here, the left lobes usually can grow almost 190% from the day of the transplant at 1 month in the recipient, while the right lobe can grow up to almost 190% from in the recipient from the day of the transplant after 1 month. So there is a significant improvement in the graft survival after living donor liver transplant. This is an old graph, an old carb, a very old carb outcome comparing living donor liver transplant and deceased donor liver transplant. You see that there is a better survival after deceased donor liver transplant. They was published in 2001, but was considering all the past experience before the year 2000. While now, in between 2008 to 2015, the survival at 1 year, 3 years, and 5 years is always better for living donor liver transplant than deceased donor liver transplant. So definitely now, with all the knowledge we have, living donor transplant performs better than cadaveric liver transplant. So who should receive a living donor liver transplant? So this is an example. 69 years old male, intractable ascites, esophageal varices, and splenomegaly. So the man is sick. He's sick. He requires hospitalization very often, and he needs every week or every other week somebody to stick a needle in the abdomen to drain out all the fluid that is accumulating into his abdomen. However, his MELD score is 12, which is very low. He will never get a cadaveric liver transplant. And because he's getting sicker and sicker, he's losing his muscle. He doesn't walk. He's barely, he can do a regular physical activity. So what we're going to tell this potential candidate? We can tell him 2 things. You don't qualify for new liver because your MELD is too low, which is exactly what happened. Most of the centers are saying your MELD is 12, so we are not putting you on the list because you don't qualify. You will never get a liver transplant, but the patient is sick. So go home and wait until your MELD increased to more than 15. Or you can say you may not be competitive for deceased donor, but you can receive a new liver from a living donor, which is a better way to treat this patient instead of keeping him in the hospital or at home going back and forth to treat his ascites. And I show you that if we are sending the patient home waiting for his MELD to go over 15, he has 30% chance to die or become too sick in a matter of 240 days. So if we are transplanting with a living donor liver transplant, okay, what happens is that he has a better survival rate and chance than not receiving a living donor liver transplant. So this is the chance of mortality at 5 years. If you compare patient with the same MELD that got a living donor liver transplant, the blue column, compared to the light blue column that are patients that did not receive a living donor liver transplant. You see their mortality is much higher than the same patient with the same MELD score that receive a living donor liver transplant. So there are also controversial indications. I want to go just quickly now, but just to give you a glimpse, an idea. that there are no contraindications to living donor. So this is a study and an experience published from Toronto, which is showing that there is an advantage to do living donor liver transplant. Also, in patients with the high MELD, they have an early higher mortality if they get a living donor transplant initially with high MELD, but then after 5 years, the chance of survival is similar to patients that got a living donor liver transplant with a low MELD. There is also a possibility that you need to have, even with high MELD, a living donor transplant because you are too small. Like this kind of patient, 58 years old, HCV cirrhosis and cancer, 98 pounds, she will never find a donor, an adult donor small for her. So the best option will be for sure to do a living donor liver transplant with the less risk for the donor because she can receive just a small portion of the left side of the liver. Or for example, rare blood type, like AB blood type, doesn't matter about the MELD. Maybe they can wait, especially if the MELD is too high and they have a rare blood type, the better way to do it is to go with the living donor in order to decrease the time spent on the waiting list. So the future living donor liver transplant is bright. Patients with low MELD are the main target for living donation. There is strong evidence, however, of superior recipient survival with living donor transplant compared to undergoing a waiting for a deceased donor transplant. High MELD score per se should not be a contraindication for living donor transplantation. Living donor transplantation for acute liver failure is feasible, and medically complicated candidate, especially with rare blood type or small candidate, may benefit from living donor liver transplantation. Our algorithm in Weston and the Cleveland Clinic in Abu Dhabi is to offer living donor transplant to all patients with a low MELD score, and then, of course, preferring a deceased donor while the MELD score goes higher. Definitely, we like to provide a deceased donor transplant for patients with the MELD above 35, unless they are very small or they have a very rare blood type. Who should be offered living donor transplant? All liver transplant candidates should be considered to receive a living donor liver transplantation. So I have concluded my presentation. I really appreciate it. You staying with me tonight, and I would be very happy to answer your question if you have any. And I hope I was clear enough to explain to you why I trust and I believe in living donor transplant. Thank you.
No, Dr. Pina, thank you. That was an absolutely wonderful presentation, chock full of information. If you want to go ahead and stop sharing your screen, then we can go ahead and see everybody. And
so do you want me to end the sharing? Yes.
Perfect. Thank you.
Okay.
So everyone, this is a great opportunity to ask Dr. Pina questions about his presentation or any transplant questions that you have at all. He very graciously is open to answering any and all questions transplant related.
I don't know where I am. We have a question. Is that me?
Yeah, go ahead.
Yeah.
That's a question if you have one.
I have a question.
Sure.
Yeah.
You can ask any question,
Okay.
even unrelated to the presentation I made.
Okay, hi, Dr. Pina.
Yeah.
Thank you, first of all, for coming on and helping us out. I have AB blood type, and my husband has O, and he's considering giving me a great Christmas present by doing a living donor thing. Can he do that?
I think so. He wants to donate the kidney or the piece of liver?
a piece of liver,
How old is he?
69.
I will not suggest that.
What?
I would not consider him as a good donor.
Oh, okay. Shoot.
Even with
Well,
a
I
clean
think,
history?
you have to remember, our paramount interest is to preserve the donor safety.
Correct.
So 69, a liver donation, it's an important procedure. Now, we can do 69 living donor kidney, for sure. And we are doing that. We even, we were able to do a living donor kidney on a donor that was 75 years old. But the kind of procedure is different. So the liver resection is quite an important procedure. And he may be at the age of 69, there may be chance of to develop a complication, surgical complication that we want to avoid. Besides, the problem is that I show you the incredible growth of the liver, right?
Right.
From the time of the resection up until 1 month. Unfortunately, there is a limit in the growth of the liver. So over the age of 50, if the donor is over the age of 50, the growing process slows down a lot.
Okay.
So I think it's gonna be better to preserve your husband, okay, and eventually looking at other potential donors for you.
Okay.
I
Thank
think
you.
I think it's good that you guys thought about a living donor transplant. It's very good. Let's work with someone. Let's see if there is somebody else available.
Okay.
I
I'm
see that you are
officially on the
scratching.
list.
I see that you are scratching a lot, so it means that you need a transplant.
Oh, yeah, I'm getting sicker.
I know. I can see from what you're saying.
Yeah.
Okay, so let's work with somebody else.
Dr.
Okay.
Peter,
Yes, sir.
can the past medical history of a living donor be an issue in the transplant?
So, well, if the donor donated a kidney and wants to donate another kidney, yes, it is a problem. But not if he wants to donate a liver.
I was thinking more or less along the lines of
Well, we made, it's not the first time that we cross a kind of a question like this. It happened to us already in the past years, and we established a line. So if the donor donate a kidney, he can donate the liver not earlier than 2 years from the kidney donation. 2 years.
Okay. I was thinking more or less, because of the coronavirus and all that. If a donor we had coronavirus in the past, would you allow him to be a donor?
Yes. If he recover from the coronavirus infection, absolutely yes.
Okay, that's more or less what I'm thinking about.
Yeah, it's very important he recover from the corona, he or she, they recover from the coronavirus infection, and absolutely, actually we did it.
Thank you.
Actually, we did it. We did it 2 living donors' livers in the past 2 years. 2 patients, 2 donors had the previous COVID infection.
If I may join in, I've got a question for the doctor. Doctor, good evening, bon dia. This
Good
is
evening.
Eduardo Fernandez. I'm a 4-month transplant recipient now.
Great, congratulations.
Good to see
What did you
you.
receive, a kidney or a liver?
Liver on June 21st.
Okay, all right.
And I'm doing very well. It's been 4 months, and I'm looking forward to another 4 months when I can get out of this incubation of a home in my immunity system.
Okay, well, you're getting close. You're getting
Yeah.
close. Okay,
My
good.
question, doctor, is
Yes.
probably one for not a lot of people here because they've been members for a long time. But my question is, as you know, I'm on a constant flow of pills. I take about 40 or 50 pills a day. And I have a set schedule of some pills are every 12 hours and some pills are like 3 times a day. And my question is the following: how specific and regimental is it on the scheduling? Like my scheduling currently is 10 in the morning, 10 in the evening. That's for Prograf, Cellcep, and so on and so on and so forth. But 10 o'clock in the evening, I am tired as a heck. And I when I do go to sleep late, I wake up every 2 hours, go to the restroom, 2 hours, go to the restroom. So if I vary a little bit, if I take some at 10:30 in the morning, and the evening ones I take at, let's say 9:15, 9:30, is that still
Correct.
safe within the realm?
Mr. Rodriguez, right? You said-
Eduardo Fernandez,
Fernandez, I'm sorry.
you
So,
left my
Mr.
my
Fernandez.
daughter in the hospital.
Everything is possible. Okay. So the timing is has been set up by us, by you.
Yes.
Okay. All right. So you can modify the timing. All right. So however, I would not recommend to do by yourself, but you have to do it together with your doctor. Okay.
Okay.
So for example, there are drugs that doesn't matter where you're gonna take it. For example, drugs that you take once a day, you can take in the morning or in the evening, all right? You can decide when. But for what is concerning, for example, one example is the steroids. I don't know if you're still taking steroids.
Yeah.
Usually the steroids can be taken, it's better to take it in the morning. Otherwise, if you take it at night, you stay up all night, all right? And then you sleep in the morning. So you rather prefer taking the steroids in the morning. But let's talk about the Prograf and the Cellcep, okay? Usually you take those two drugs, one dose in the morning and one dose at night.
Correct.
The most important thing is that you need to have 12 hours apart from the two doses, okay? And the dose in the morning should be always set up in order for you to take the drug after they do the blood work. So you understand what I mean?
Yes, correct.
We told you to do at 10 o'clock at night because the day you have a clinic, you come at what, 8 o'clock, 7:30. So we are sure that they are taking the blood before you took the pills. So we have a better idea of the level of the program. However, there is always a way to accomplish, and I totally understand your point, totally understand. So there is a way you can work with your doctor. For example, number one, you can say, what about we do 9 o'clock in the morning or 8 o'clock in the morning and 8 o'clock in the evening, okay? Because what you say is very important to avoid uncompliance. If they're telling you, take the pill at 10 o'clock at night and you fall asleep at some point and you will forget to take the evening pill. If that is going to happen 2 days, 3 days, 4 days in a row, you're going to mess up everything, okay? So you need to tell them. So what you can do is to move the evening dose at 8 o'clock p.m. as far as you take the morning dose at 8 o'clock a.m. The day you do blood work in the clinic, bring with you all your pills. Don't take it. Don't take it in the morning. Don't take it in the morning. Just go to the lab with the pills in your pocket. You wait until they withdraw the blood, and then you take the pills.
Correct. I've been doing that.
So you're not losing them. Then there is a second option for the program, okay? But this is a little bit more, is a little bit trickier. And I, again, strongly advise to don't do it on your own, okay? Which will be to move to the long release program. So instead to take one dose in the morning and one dose in the evening, there is a long release program that you can take only once in a day in the morning.
Huh, I didn't know that. Oh, okay.
Yeah. Okay.
Very good, doctor. Thank you
So
very much.
you need
Oh.
to talk talk to your doctor, sit down with them, with your coordinators, and make sure they understand your needs. We need to match your needs, not the way around.
Very good, doctor. Thank you. It's always good seeing you too.
Okay, sure.
And thank you for my life.
Dr. Pena, can I ask you a question?
Oh, Dr. Wright, hi, how are you?
Good, you know, we work closely. I'm a newcomer on the team for others, and work
Okay,
closely day in and day out. But you know, it's a beautiful thing that you're doing, and I'm wondering. We haven't talked. Are you, you know, as the father of this field, a pioneer of this field, is it your dream that this will happen at many transplant programs, or do you envision this as a specialty area where few experts offer this to those patients on the, you know, on the wait list that are candidates? I haven't even asked you, but I don't think there are other programs doing this. I don't know in Florida or not.
in Florida there is nobody.
Nowhere in Florida.
I told you, I think I remember, I told you, I did my first here in Florida in 1998. We did several until I moved back to Italy in the year 2000. After the year 2000, I know Dr. Tazakis did a couple more, but then he stopped. And then if you remember the slide I projected, where you see the two livers completely separated, there was a date. It was 2001. It was my first living donor when I went back to Italy. Okay, it remains as a figure. So going back to your question, which is a very good question, I think there is an answer. It's a very delicate procedure. There is no question about it. It should be done. It doesn't matter the volume of the center. What it matters is the support that the center has in terms of ICU, interventional radiologists, and interventional endoscopists. These are the three main factors. And then finally, you need to have a team of surgeons that have knowledge in major liver resections and of course in the procedure. That's are the two main, the four factors that are impacting the potential success of a living donor. And this also explains why not many centers are doing, because the procedure is time-consuming, stress-consuming. It takes almost 1 month just to prepare one case. And unless you have 20 people. Now in South Korea, in Seoul, the hospital that I visited, Asan Medical Center, they have something like 35 people, 35 surgeons, not people, 35 surgeons working only on living donor transplant. And they're doing 2 living donor transplants in a day. But there are 35 surgeons. So not everybody has this kind of capability. It's serious, however, brings a lot of knowledge to the team. And my dream will be to expand the number and expand the centers they're doing as far as they're doing it the same way, providing donor safety first.
Great, thank you, Tony.
Sure.
I have a question.
Yes, who is Alice?
Yes, it is Alice.
It's asking, okay.
Nice to meet you, and this is
Nice meeting.
so interesting to learn about. My concern is this, and I'm guessing maybe some other patients are thinking about the same thing. With the new variants that are of concern for transplant patients, at this time, what is the hospital planning for patients who may come down with COVID? I've heard remdesivir, I heard, is done in inpatient services, and I'm wondering if it can be done as outpatient service. Has there been discussion at the hospital about what to do with the transplant patients when Evusheld and the vaccines don't work for us. That's frightening.
Yeah. So one thing I learned with the COVID is that everything changed and you need to be flexible. For what is going back to your question, which is very appropriate, we develop this kind of strategy now for transplant patients. So number one, of course, we are requesting all recipients, all candidates to get a vaccination, to get vaccinated. That's the number one point. And the important thing is that the patient needs to be vaccinated before transplant. If you get a vaccination after transplant, the chance to work is minimal, okay? So patients should arrive to transplant already vaccinated, at least with the 2-3 boosters. After that, after the transplant, we provide Evusheld infusion to everybody, to all transplant recipients, before they leave the hospital, in order to add to the immune coverage done by the vaccine, also another umbrella coverage from the antibody provided by the Evusheld. If there is a need of treatment, because transplant recipient maybe gets sick regardless from a potential infection or reinfection of the COVID, I think now there are very valuable antiviral drug, much better than remdesivir, that can work if the diagnosis is made immediately. However, I think that for transplant recipient, the rule should be vaccination before transplant, Evusheld at the time of the Evusheld or another antibody at the end of before discharge after transplant, and then possibly maintaining a mask whenever they are meeting when they are outside.
Okay, that is what I think most transplant patients are doing. But the concern is to think ahead and plan. What is, I know that the health department is looking into it, and that I know that they're trying to share information so that hospitals, transplant centers, and local hospitals will be prepared with what to do in that event. I don't know that they have an answer right now, but what I'm learning is that remdesivir is the one that is working and will prevent COVID in the next couple of months. That's the only one that's working.
I'm sorry, Ms. Soskin, remdesivir doesn't prevent you. It may treat you.
Oh, I meant treat,
Yeah.
yes, I'm sorry.
It may treat, well, make sure that it may treat you if you get the infection, but it's not the only drug. The new antivirals that are being released 6 months ago are very effective. I can tell you because I use it for myself.
Okay,
Okay.
thank you.
I was under the two potential treatment, Evusheld or the antibodies or these new antiviral, which was name is Pavlixdel, and it actually worked pretty well.
Bebtel,
Yes.
Bebtelovimab. Yeah, it's hard to remember how to say that.
Yes.
So that did work.
It did work. Yes, I mean, at least on me it worked. I got 5 boosters already of vaccine and 3 infections. Quite a veteran.
Oh my goodness.
Yeah, but thanks God, you know, I have to admit, except the first time, the other, which I was after a single dose of vaccine before the second booster, the other 2 times was a real like a flu, no more than that.
I was feeling comfortable knowing about the success of and that's why I have practiced.
Alice, get vaccinated.
I am.
And wear a mask. That's what we need to do.
That's what I'm doing.
Vaccination and wearing a mask.
Dr. Pina, one more question for you, sir.
Sure.
Has Cleveland Clinic signed off on any particular antibody test? I inquired about it and they didn't have one that was totally acceptable to Cleveland Clinic.
You're asking me antibody testing for COVID?
Well, I'm a heart transplant patient and I just was wondering if they had, they didn't say they were very successful. Whether they actually were producing.
No, we are not testing antibodies.
Okay.
We are not testing antibodies. It's not that we don't believe it, but we are not testing antibodies.
Dr. Pina, how are we doing on time for you?
I'm sorry?
Do you have time maybe for just one or two more questions?
Yeah, let's make two more, absolutely. Two more questions, absolutely. And sure.
Thank you so much.
Sure.
I have a question. Hi, doctor. Thank you for your presentation.
Sure.
I have a.
What is your name? What is your
Nicholas.
name? Nicholas.
I have a little bit more general question. I'm about 3 years out from my liver transplant, doing well.
I'm sorry, how many years out?
About 3 years now.
Okay.
February will be 3 years. And like the gentleman before me, I guess his name is Ed, issues with medications always come up. I happen to be a pharmacist, so I'm a little bit ahead of the curve, so to speak. But speaking as an advocate, it is a complicated issue in terms of drug interactions and meals and low salt and how much potassium and all that kind of stuff. So I would ask you if you might be willing to comment on, I guess you might call them pitfalls of dietary issues before and after transplant for both kidney and liver. And also a second part, or like they do in politics, a follow-up question. Just general comment about the atmosphere regarding COVID. We here at this meeting always talk about vaccination. I'm sure we all have them. I'm vaccinated completely. I received the Evusheld as well. Always wear a mask. But if I'm not mistaken, everywhere I go, which is relatively limited, and most people are not wearing masks anymore. It's like it doesn't exist. I know it's not that way in the hospital, mostly, I guess. But going to Home Depot and going to Publix and, the usual stuff, which I stay away from, it's like there is no pandemic anymore. And I understand that the numbers have gone down significantly. But it still could be considered an endemic, if I'm not mistaken. There's still how many hundreds of people dying every day, 100, 200, 300, I don't know. They never report the data anymore. They just ignore it. So for the people at this meeting, it's still critical, in my opinion, to be safe. So I wanted you to comment on that, if you would, please. Thank you.
Thank you, Nicholas. Thank you, Nicholas. I totally agree with you. We need to be safe, to stay safe. So let me go back to the first question, which is the interrelation between food and drugs, right? If I understood, for the regulation of the electrolytes that we are detecting in the blood. I think is a very complicated matter. Okay, we can spend more than 2 days to discuss the interaction between food and drugs. And at the end of the day, we still will have a lot of shadows, because then it depends how much you're absorbing from the food that you're eating, which kind of food you're eating, how is the function of your bowel, what is the macrobiota, the kind of bacteria, the bacterial flora that is happening into your intestine that can actually make the difference. So we are eating both the same thing, and my potassium goes to 6 and your potassium stays to 4. Why is that? All right, so there are a lot of shadows that we still don't know. And that's, please take it for granted. We still don't know. We still have to learn. The rule of the thumb is that for a patient taking Prograf or cyclosporine, steroids, Celcept much less, but with these three drugs, you need to stay away from any potential potassium carrier, which is lemon, orange, bananas, tomatoes, you name it.
Avocados.
Of course. I'm sorry, yeah, please, you know better than I. So and the other thing that we need all to understand is that unfortunately some patients don't have a perfect kidney function, especially the liver transplant recipient. Paradoxically, the kidney transplant recipient they have most of the time a perfect kidney, so their function is normal. But the liver transplant recipient, unfortunately, due to the previous disease, the timing of the liver disease, they have a not perfect kidney function. So they have a much higher chance or risk to develop hyperkalemia or hypomagnesemia secondary to interaction of diet with the Prograf and the steroids or the cyclosporine. That's unfortunately the problem. I think probably I'm not going to be the right person to speak about this, but I think this is a very important topic. Thank you, Nicholas, to bring it up. And I think FOTA should organize a meeting with a nutritionist and a pharmacist together to talk to all the transplant patients about this interaction. Okay, that's talking about food and drugs. So let's go to how to stay safe. I want just to remind you one data that you probably guys know, folks know, and it probably is not, we are not retained enough. During the pandemic, we were afraid to get the COVID. So the only barrier before we actually got the vaccine was the mask. Do you remember that? It was the mask. Now, do you know how much was the rate of flu infection during 2021?
0.
Well, not 0, but was very low, minimal.
Low, very low.
Minimal, to the point, and you probably don't know this, to the point that in 2020, when we start receiving patients infected by COVID in the emergency room, the usual test that was run was not the COVID test, was the flu test. Because we want to discriminate patients infected by flu from patients infected by COVID. And because we did not have a provided test for COVID, we were doing a flu test. Nobody got flu test positive. Nobody. Okay? So that's to tell you how much important it is to wear a mask. Now, you know, the people from Asia, they used to wear a mask very often. Did you remember, guys, folks, the past year when we were seeing Japanese tourists storming into our cities? They were wearing a mask, and we were saying, "Oh, what's silly wearing a mask? Why is that?" Because they knew the problem. They knew before us. So I totally agree. We should wear a mask. The Cleveland Clinic policy at the present time is to wear a mask, doctor and patients. Then everybody can come in the hospital. We don't have any more limitation, but wearing a mask is important, as well as getting a vaccination. We need to be safe. And I agree, there is a false perception that the pandemic is over. The reality is, yeah, it's a false perception. The reality is that we got sick and tired of the pandemic, and we like to be over. But it's just a matter to adjust ourselves to a different dimension. I'm not wearing a mask now, right?
I
We
have
learn a lot of new things. Thanks to the pandemic, we learned a lot of new things.
So as pre-liver transplant, what foods do I need to avoid now?
Uh,
Tomatoes?
well, if you are waiting for liver transplant, you don't need to avoid tomatoes. You need to avoid the raw meat. If
To
you are
what?
before transplant, the concern is not the potassium. The concern before transplant is to avoid the high protein intake, either if you're waiting for a liver, either if you're waiting for a kidney.
High protein or low protein?
High protein intake. You should be low on the raw meat. Don't eat raw meat.
No,
Okay?
a lot of fish.
Fish can be good. Well cooked fish, no raw fish, nothing raw.
Or raw fish.
No sushi. Okay, that's fine.
No, please, no sushi.
Okay.
Very dangerous, very dangerous. For a
What?
patient with liver disease, raw sushi is dangerous.
Yeah, okay. Yeah, and I worked in Japan and everyone wore a mask all the time anyway.
Right, exactly.
This
So
was,
I think we should arrange a meeting with all of you folks talking about nutrition and liver and kidney disease. So two different things: nutrition in patients with liver and kidney disease, and interaction between nutrition and drugs
okay,
after transplant. So there are two different topics.
okay. And who was the player from Barcelona that was a living donor?
Abidal,
Really? Wow.
he played the final, eh? You see him?
Yeah, and I was in Japan
Yeah,
in 2000 when they had the World Cup.
yeah, he played the final.
Yeah, so I'm very excited.
Yeah,
Okay, thank you.
Thank you.
sure. Thank you. Thank you very much. Well, thank you very much. It was a pleasure for me to stay with all of you. Thank you.
Dr. Pina, thank you so much for spending some time with us tonight. And we hope to see you with masks on for our holiday party on December 3rd at Signature Grand.
Perfect. Thank
Please
you.
come and join us.
Thank you very much. Bye. Good night. Good
Thank
night
you,
now.
doctor.
Bye,
Bye.
everyone.
Bye.
Have a great night. Thank you for joining CODA for Transplant Topics.
Bye.
Thank you very much.
Thank you. We all want to see you socially, not professionally. Hey, James, how are you? James.
Brian, how you doing?
It's good. Hang on the radio.
You got up, John, you got up to 37 people tonight.
Yep,
That was good. Very good.
worked out nice, yeah. He did
Very
a
good.
good job, he really did.
Yeah, it's fascinating.
A little
That's
broken
good.
English, but that's okay.
All right.
I always thought they wore masks in China because of the air pollution.
Well, that too.
That too.
Yeah,
Yeah, that too. China and Japan, because there's so many people jammed in a subway. You saw those videos of people. They have people just jamming people into the subway. They all wore masks
yeah.
for
I
years.
always said, geez, what the heck? How could you live like that, having to wear a mask all the time? And here we
Now-
are, where everybody's wearing a mask.
Now you
Almost
know.
everybody.
Well, they're not wearing them much anymore. That was my point. That's
Yeah.
what scares me, because we have personal friends. I would say 100% of whom are completely vaccinated and boosted. And now they're getting flu shots, of course. Almost everyone but my son, who is completely vaccinated, every single one of them got COVID, except my son. Everyone. And 2 or 3 of them got pretty sick. Not hospitalized, but felt pretty crummy at home. Pretty bad.
Yeah.
So that tells me that it's out there. Don't give a crap. Other people don't care about us.
Oh, I know. Well, you know, when we go to store, James and I, we both wear masks and people look at
Oh,
us like, why are you still wearing a mask?
Yeah,
You know?
yeah.
Because I'm wanted in 3 states.
Yeah.
I go to Publix once in a while or Home Depot. I have to run in and grab something. I'm like, maybe 1% is wearing a mask, if that.
Yeah.
I ignore it. I don't care.
My son works in Publix, so we have all our food delivered to the door.
Anyway, that was very good. He's a Cleveland, Dr. Pina.
Well, I can tell you, I get, see the numbers weekly from the CDC, and there's still 2,000 to 3,000 people a week dying in the country from COVID. And there are new subvariants that have been identified. And one of the bat populations in some cave somewhere they recently discovered actually has, I guess, what will soon be called the SARS-CoV-3 virus. And the preliminaries on that one indicate that none of the current vaccines will work. So they're working on already, I guess, starting to work on a new vaccine for that one.
Brian, more people are dying from car accidents, so you ought to feel lucky, right?
Hey, you guys don't know, Brian is he's with the United States Coast Guard, and he's the guy who helps us with the Marina Day for the kids.
Nice.
He helps us put it all together.
Yeah, so I'm also still have a license as a physician assistant, although I'm somewhat retired.
Yeah.
Your number 1 commander is a female now, Brian.
Oh, the sector captain. Yeah, well, actually, it has been. The previous one was also. So
she has a stateroom painted pink, I understand.
Well, that I wouldn't know, but hey, don't worry. Hey, even the commandant is female right now, so
that's what I'm talking about. The commandant of the Coast Guard.
Oh yes, I know, and the Sector Miami commander is female, so
yeah,
hey, the Coast Guard is equal opportunity.
That's it. A good friend of mine retired after 20 years in the Coast Guard.
Yeah, I know. And right now, these days, everybody is short-handed and understaffed.
Yeah.
Oh yeah.
Like on the they're talking about that the Coast Guard is short on cooks. So, and they're offering like up to $50,000 bonuses.
Wow.
Hey, John, do you know if Dr. Pina, does he teach as well? Or does he just do surgery at Cleveland Clinic?
He probably has students that he does teach, but I'm not positive about that.
Well, I'm sure he has residents and fellows. I'm sure.
Yeah. I'm sure he talks to the students there too.
Yeah, he teaches there. Yeah. All right. Very good. He was terrific.
Yep.
Yeah.
Good choice.
Yeah, it's interesting. Our group is so willing and interested, and I know, as in the case of with other people, I've heard, we know someone in his 30s who doesn't want to come to these meetings. He's not even on the list yet, as far as I know.
Yeah.
But he's kind of still in denial, at that phase early on. And so we brought it up once or twice and we let it go, because you can't force anybody to do anything, even if it's for their own good, at least just for information purposes.
Well, we had that guy that was waiting for a liver, if you remember, the young guy. He
Yes.
was drinking, I guess. So I emailed his mother just to find out how he was doing. She was coming along, but she didn't say he stopped drinking or anything like that. So I don't know what's going on with him. But when you got two kids at home, little kids, do you think you'd want to live?
Well, there was the guy up in Boston at Boston, teachers and the doctor hospital in Boston, and he had he was married with 2 kids and his wife was pregnant with a third and he refused to get a COVID shot, but he wanted a heart transplant.
Nice.
He said, "You're out of here."
People they're crazy like that. It's unexplainable. Inexplicable, whichever the more correct word is.
Don't
Makes no
confuse
sense.
them with facts. Their mind is made up.
It doesn't make any sense.
No,
Well, they won't do it then, right? They won't do
no,
it.
they told him he's off the list.
Oh, well.
No, yeah.
All
Not
right.
even gonna get a COVID shot.
I guess it's safe to say goodnight, gentlemen, because I don't see any
In
ladies
case
left.
anybody is interested, I got my shot, my 5th shot and my flu shot at the same day. If anybody, 2 different
Awesome.
arms, but you can do it.
Okay.
Hey, I heard there was a lady I read about once that she needed a heart transplant and she kept refusing. One was from a black person. She said no. A Hispanic person, no.
Really?
You know, and she ended up dying.
There was some clown wanted to know if it was okay if he got a female heart. No,
Yeah.
stupid, don't do it.
I
Hey,
told you
listen,
my
we're not
my
all
friend-
we're not all MD PhDs out there. You know what I mean?
my friend Jan got a kidney from a guy, and everybody kept asking her, "Do you feel any different? Do you feel?" So she said, "No, it's just I could stand up and pee, but I can't write my name in the snow."
On that note, I'll see you, gentlemen. Take care.
All right,
night,
take care.
gentlemen.
Oh,
Bye-bye.
remember the support group is earlier this month, okay? Because of Thanksgiving. But
Hey,
we'll let
John,
everybody know.
James
Thanks,
has
John.
got, John, James has got his speaker off. Could you say hello to him for me? John,
What?
James is muted, so I wanted to say hello to him.
James, you're muted. Unmute.
Yeah, there you are. Hello, James. I
There
wanted
it
to
is.
say hello to you, but you couldn't hear me.
How you doing, Owen?
Very well. How's that dog of yours?
It's doing okay.
You got to let him outside so he can get dirty once in a while.
Yeah.
I took him for a walk twice today and he pooped both times. James will take him out later and he's gonna poop again.
There you go. You wonder who's in charge, the dogs or the humans?
Oh, definitely the dogs.
Oh, in this house, the dog.
Okay, have a great night, boys.
All right, take care. Yeah.
John, when is the next meeting?
Next meeting is gonna be the 17th.
Okay,
All right, well, we'll send you the flyers. So,
thank you.
Brian, we're having our holiday celebration on December 3rd. So circle that day, okay?
All right, I'll see what I can do about that.
If you can make it, it'll be nice. It's from 12 to 4 and it's in Davie, Signature Grand in Davie. All right. I'll send you a flyer on it anyway, so,
I appreciate it.
all right?
All right.
Hey, good to see you. Thanks for coming on.
All right, it's a nice little educational thing, and I happen to be home because I got to be here on the radio at the same time for the Coast Guard emergency net test. So, all right, well, thanks for the invitation. I appreciate it. It's good
All right.
information.
Take
Yes,
care.
I know I'm too old to give part of my liver.
Oh, yeah. Well, that's what he was saying. I didn't realize. I thought it was a higher cutoff, but
Yeah,
Yeah.
I thought so.
wow.
Oh, well, you know something, if they get desperate enough or they may actually bend the rules.
Well, originally they did that with kidneys. It was up to a certain age and then they upped it. You know,
Oh, yeah.
and also if you needed a kidney, it was a cutoff too.
Oh,
But
yeah.
now it's up to 80, 85 or something like that,
Mhm.
that you can still get a kidney transplant.
Yeah, just don't go to the parts of some countries in Europe because they still at like 75 or 80, will cut you off.
Yeah, yeah. Oh, well. All right, good seeing everybody.
Oh, same here.
Thanks
Bye-bye.
again.
All right.
Take
Bye-bye.
care, Jose.
Hey, have a good
Thank
night.
you. Bye-bye. Have
Bye.
a good night.
Night. Take care.
I'm signing off.
All right, good night.
Good night.